Today's webinar presentation will begin in 3 minutes. Today's webinar presentation will begin in 1 minute. Welcome to today's webinar, Managing Syphilis in HIV-Coinfected Patients, a case-based approach. I would like to introduce Khalil Ghanem, MD, PhD, Associate Professor of Medicine at Johns Hopkins University in Baltimore, Maryland. Welcome, Dr. Ghanem.
Jose, thanks so much. It's a pleasure to be here. Thank you so much to the IAS for inviting me to give this webinar. We're going to have a blast. We're going to have an hour and 15 minutes, and I'll stay longer if anybody has questions afterwards. I'm going to start with some basic housekeeping issues, and then we'll start with the webinar. So for the next few slides, it's going to be a few housekeeping issues. For those people who have not previously logged in on the new website, you'll need to use your email address and reset your password. So please use your email address to reset your password, and you'll be able to log in. The IAS-USA designates this live activity for a maximum of 1.25 CME credits, but it also is approved for 1.25 hours of nursing, pharmacotherapy, and pharmacy credits, which is great. And the evaluations, and this is really important, the evaluations are going to be available in your IAS-USA My Activities page by 5 p.m. So you have till 5 p.m. Pacific Standard Time. For those of you who are living on the East Coast, you have till 8 o'clock tonight. And if you're on the Pacific time, till 5 p.m. tonight to fill out those evaluations. And generous support for this activity has been received from the contributors that are listed on the slide, and we thank them very much for that. just to remind you that a separate window is going to show up for the poll questions. So all you have to do is click on that window to answer the poll questions. Choose your response from the poll. Don't put in your response in the chat box. And then the responses are going to be displayed after the poll closes. But do type in your questions into the chat box. So questions will go into the chat box. The poll responses will go onto the special window for the poll. Here we go. Without further ado, the first poll is going to be essentially from which geographic region are you viewing this webinar? So please remember to click on the poll result that's right there in front of you. All right, I think we've closed the poll. And let's see what's going to happen next. There we go. All right. And now we're going to move to the next poll, and that is, when will the evaluation for this webinar, which you must complete in order to claim CME or other credit, be available on My Activities page in your IAS-USA account? So we're testing your knowledge on what time do you have to, maximum time you have to fill out this evaluation. So please answer the poll question. All right, and this poll question is closed now. Great job. You're absolutely right, by 5 p.m. Pacific time today. Good job. And then we're going to move to the next one. Please rate your level of experience in HIV prevention. If you're a novice, go to 1, and if you're an expert, go to 5. Fabulous. The poll now is closed for this question. That's great. Thank you all for answering these questions. And this is me again, and so welcome again. Thank you so much. And today we're going to be talking about syphilis, and I'm going to start by talking about the epidemiology of syphilis, and then I'm going to talk through some cases which I hope you'll find useful. So my financial relationships, the only thing I have to report is that I receive royalties from Up to Date, but they are not related to this talk. And then here are the learning objectives. We're going to talk about the epidemiology. Then we're going to move to the diagnostic approach and the treatment approach by working through 2 patient scenarios that I hope you'll find useful. So without further ado, let's start with 2 pretest questions. So here are the pretest questions. So the first pretest question is essentially a 26-year-old individual who essentially forgive me one second. I am losing my, is there any way to move the pretest slide a little to the right? Because I don't seem to have that printed up. Yes, there we go. If you move it away to the right from the, yeah, there you go. That'll be great. So a 26-year-old man whose CD4 count is 634 and HIV RNA is undetectable presents with clinical and serological evidence of secondary syphilis. So this man has secondary syphilis, and he has new onset bilateral tinnitus. He has no other neurological or ocular findings. So no other neurological or ocular findings. Which of the following is the most appropriate next step to treat his otic findings? Perform a lumbar puncture, treat with benzathine penicillin G times 1, treat with benzathine penicillin G times 3, or treat with intravenous penicillin for 14 days. So please answer that question. Thank you very much. All right, so we have about 42% are saying perform a lumbar puncture. That's wonderful. All right, now we're going to move to the next slide, and that's also going to be the final pre-test question that's there. And this is a 62-year-old asymptomatic woman whose CD4 count is good and whose HIV RNA is well controlled. She's married and monogamous, who presents for an initial clinic visit. Her routine screening serologies reveal a reactive treponemal CIA, a non-reactive RPR, and a reactive TPPA. So she's got 2 reactive treponemal tests and a non-reactive RPR. Which of the following is the most appropriate next step? Obtain additional history, treat with benzathine penicillin times 1, treat with benzathine penicillin times 3, or perform a lumbar puncture. Fantastic. Now this poll is closed with about 70% that said obtain additional history. Thank you very much. All right, ladies and gentlemen, without further ado, let's get started. So the first thing we're going to do is start with the epidemiology. The reason why is because it's important to know who's at risk for getting syphilis so that you know who to screen for. And this is where we were in 1999. We had had the lowest rates documented of syphilis in the United States. And that essentially forced the CDC to come out and say, listen, we are going to eliminate syphilis over the next 10 years from the United States. Unfortunately, right after this came about in 2000, 2001, the rates of syphilis started increasing, and they have not stopped increasing since 2001. The rates started increasing among men, particularly men who have sex with men, and those rates have continuously increased since 2001. And there has been a greater than 75% increase in this population since 2013. About 42% of our MSM who are infected with primary or secondary syphilis are also HIV infected. And please remember, like with any other sexually transmitted infection, nearly 30% are going to be reinfected 3 to 6 months after you treat them today. And that's why it's really important for all sexually transmitted infections to go about and rescreen them within 3 months. So initially, the first epidemic that we saw starting in 2001 was among MSM. Now, unfortunately, over the last 5 years, there is now a second epidemic that's occurring. So the MSM epidemic is occurring, and concomitantly, over the last 5 years, there is a second epidemic that's occurring, and that is the heterosexual epidemic. Unfortunately, among women, for example, between 2014 and 2018, there was an increase in primary and secondary syphilis of about 173%. And just between 2017 and 2018, a 30% increase among women. That is horrifying on so many levels, and it suggests that right now we have 2 epidemics, one amongst MSM and one amongst heterosexuals. So we need to be aware of that in order to screen appropriately and manage these patients appropriately. Now, the heterosexual epidemic is really an intersection of epidemics. It is an intersection of the epidemic of drug use and heterosexual syphilis transmission. In fact, it's been shown that this heterosexual epidemic is related closely to injection drug use, methamphetamine use, and heroin use, particularly on the West Coast, but pretty much throughout the United States. So if you see a patient who uses injection drugs, methamphetamine, or heroin, keep in mind that it's going to be important to make sure that you don't miss syphilis in this population. Of course, when the rates of syphilis start increasing among women, then the natural fallout is that you're going to have increases in congenital syphilis. And unfortunately, that's exactly what we're seeing. Between 2017 and 2018, the number of reported cases of congenital syphilis increased 40%. Now we're at about 1,300 cases in the United States. That's a 185% increase relative to 2014, and that is really horrifying because congenital syphilis is a completely preventable infection. If a pregnant woman is diagnosed early and treated quickly, it is a preventable infection. And unfortunately, this should be no surprise to anyone that there were documented 78 syphilitic stillbirths in 2018 and 16 infant deaths. And that is most likely an understatement and an underreporting of the consequences. These are all data that were just released last week from the CDC. If you're interested in these data, you can go to the CDC website and download the 2018 surveillance report. So we know how to manage syphilis, like we know how to manage STIs, and we've done essentially, our approach has been the same since Thomas Perrin essentially published his Shadow on the Land in 1936. So we find cases through serological screening, we treat those cases, we find the partners, we treat the partners, we do serological screening for those people who are at risk, and we engage in public education. That is an approach that we've used since 1936 to try and control STDs, and that approach works. And there's no reason why it shouldn't work right now, but there are new challenges, though, to that approach. So why are we failing? Unfortunately, screening rates, even in high-risk populations, are very low. This was a poster by Alex DeVoe from the CDC that showed that even in very high-risk MSM who are receiving care for HIV in the United States, a significant number were not even screened once during the year, and for those that should have been screened at least every 3 months, very, very few of them were screened every 3 months. So we're not doing a great job screening. Also, another challenge is that we're having a hard time finding the partners of patients, particularly when those partners are met online. It's really hard to find partners that you meet online, and that's another reason why it's becoming more difficult to actually go after the partners and treat those partners immediately and effectively. And then finally, the biggest reason why we're failing is because it costs money to essentially control STIs. It costs money to do these interventions. And unfortunately for us, over the last 15 years, the budget to the CDC, which is responsible really for allocating the money to the states to try and control STIs, the budget has been flat, which essentially means that over the last 15 years, there's been a 40% decrease in purchasing power for the CDC to run these interventions. This past year, there's been a slight increase. That's great, but unfortunately, it's still very limited, and it's going to take a lot more money to be able to control this epidemic. So as a summary, it's important to remember who is getting infected, who's at risk for being infected, because it's important to screen. We need to do a better job screening. I want to highlight this lovely online, available for free, the Diagnosis, Management, and Prevention of Syphilis from the New York City Health Department. It's a wonderful review of syphilis that can be downloaded for free, and I will show you the link to download it at the end of my slides. It's great because it has a summary of who should be screened, and amongst persons living with HIV, you should be screening at initial HIV evaluation and at least annually if sexually active, but remember, more frequent screening, that is every 3 months, in some people with ongoing risk and high risk of infection and reinfection. And then they tell you who those people are, and those are people with multiple or anonymous sex partners, a recent bacterial STI, use of recreational substances, including meth, participation in sex parties or sex in other high-risk venues, and participation in any type of transactional sex. So these are, in particular, the people that you should be screening more frequently. And so to summarize the epidemiology and move next to the cases, please remember, identify people who are at high risk and screen them. MSM, heterosexual men and women, particularly those who use drugs, but always ask about activities and behaviors rather than thinking that your patient is not at risk. Also remember that frequent screening of high-risk persons is critical, and in some cases, like like we just talked about, quarterly screening is very appropriate. And also remember, screen pregnant women and don't assume someone else is doing it. You don't want to miss syphilis in pregnancy. You saw the consequences of that. So what you want to do is screen them. If you find it, immediately treat them, and then call the health department to let them know so that they can follow up with those patients. So that is the epidemiology of syphilis. In a nutshell, remember you can download the latest data for the U.S. on the CDC website. So now let's talk about management. And I'm going to briefly go over the natural history of syphilis for those of you who are not as familiar with it. So the natural history of syphilis, you get infected through sexual contact in general. And then there is an incubation period. Now, it's very important to keep in mind this fact because it explains a lot about syphilis. When you get exposed through sexual contact, within hours to a few days, the organism has already spread, and in many patients, it's already in their central nervous system. And this is weeks before the development of the primary chancre. So syphilis spreads very quickly through the body into the central nervous system as soon as you get exposed to it. And that's the reason why the central nervous system complications of syphilis can happen at any stage in the infection, early or late. So there's incubating syphilis, and then a few weeks to a maximum of about 8 weeks after the exposure, you get the primary manifestations of syphilis, which is usually the ulcer or the chancre. It is classically described as a single painless ulcer that develops at the site of exposure. If the site of exposure is the genital tract, that's where it develops. If the site of exposure is the mouth, that's where you will see it. And if the site of exposure is the rectum, that's where it will be. And so primary syphilis is essentially the chancre, and sometimes you'll see localized lymphadenopathy. Keep in mind, though, that 30 to 50% of patients will have multiple lesions, not just a single lesion. And they will also have painful lesions rather than painless lesions. So the old adage that it's a single painless lesion is not accurate. 30 to 50% will have multiple lesions that are painful. Keep that in mind. Now, if you don't treat primary syphilis, the immune system will kick in and clear it. And then there's going to be essentially a latency phase where the patients are asymptomatic. They don't have any symptoms. And then about 4 to 8 weeks later, after the primary chancre disappears, you're going to get into the secondary phase. And the secondary phase is the phase where you see everything happening. Essentially, you will see evidence of rashes. That's where the diffuse rashes occur. You will see evidence of mucosal lesions, whether they are mucus patches or essentially warts, condyloma lata. You will also see evidence of hepatitis, gastritis, lymphadenopathy, fevers, and so secondary syphilis is essentially the time when you see all of the classic clinical manifestations of syphilis happening. Now, if you do nothing, if you don't treat the patient, the immune system will kick in and clear the secondary lesions, and the patient goes through a phase called the latency phase. The early latency phase is described as from 1 year from the time of exposure. So in other words, from the time of exposure up to 1 year when there are no signs or symptoms, that's called the early latency phase. After 1 year, when there are no signs or symptoms, that is called the late latency phase. The reason why we divide that is because the treatment differs. In early latency, up to a year from the time of exposure, you treat all stages of syphilis, essentially primary, secondary, and early latency, and that's called early syphilis. You treat them with a single dose of benzathine penicillin. With late latency, it's treated with 3 doses of benzathine penicillin, 1 dose each week. And so treatment is different between early latency and late latency. And then the tertiary manifestations of syphilis, in other words, the late manifestations of syphilis, occur years to decades after the initial exposure, and those can be cardiovascular in nature, or they can be late neurosyphilis, and we'll talk a little bit more about that in just a bit. And you can also see late ocular and otic syphilis. So the tertiary manifestations tend to occur many years after primary exposure. Now, I want to highlight something very important, and that's early neurosyphilis and early ocular and otic syphilis also take place. Remember, the organism is already in the central nervous system even before primary syphilis. And so these early manifestations of neurosyphilis, ocular syphilis, and otic syphilis can also take place. So remember, neurosyphilis, ocular syphilis, and otic syphilis can occur during any stage of the infection, early or late. Also remember, when you diagnose neurosyphilis, ocular syphilis, and otic syphilis, the treatment becomes 14 days of IV penicillin. 14 days of IV penicillin, whether it's early neurosyphilis or late neurosyphilis, whether it's early ocular or otic syphilis, or whether it's late ocular or otic syphilis. So please keep those very important things in mind. So now let's talk about cases. Our first patient is RJ, and he's a 38-year-old HIV-positive gay man. CD4 count 190 was recently started about 4 months ago on antiretroviral medications, and he's undetectable. He presents with low-grade fevers and a rash for 3 days. He noticed a painless ulcer that appeared on his penis a week earlier, and severe rectal pain associated with defecation. He's had PJP, pneumocystis pneumonia, in the past. He's also had gonorrhea in the past, including 1 episode of pharyngeal gonorrhea. He does not smoke. He does not use drugs. He's had 3 sex partners in the last 3 months, all HIV positive, and he's had inconsistent condom use with those partners. On physical exam, he has a diffuse rash and a penile ulcer, and I'm going to show you that on the next slide. He has exquisite tenderness on digital rectal examination, and he has no lesions noted around the anus or any other mucosal sites. And so this is RJ's pictures. These are the pictures. And so you can see here, he essentially has the ulcer, which is a classic, well-demarcated, painless ulcer, and you can also see the rash that he has on his body. Now, the laboratory results show that he has a treponemal CIA, so the treponemal test is reactive. His RPR is reactive at 1 to 32. The NATs, the nucleic acid amplification tests from his rectal, pharyngeal, and urogenital sites are negative. His rectal HSV PCR is negative, and they ordered LFTs, liver function tests, and what they found was a slightly elevated AST and ALT with a very, very high alkaline phosphatase. So the alkaline phosphatase was elevated disproportionately to the AST and ALT. So what is the clinical diagnosis, or what are the clinical diagnoses of RJ? And so it appears from what we see is that there is an overlap of primary and secondary syphilis stages. He has the ulcer and he has the diffuse rash. He has syphilitic hepatitis. His alkaline phosphatase is very high. ALT and AST are only slightly elevated. And he has syphilitic, most likely proctitis, which in this case is causing a lot of pain. And remember, early syphilis can involve the rectum and can cause syphilitic proctitis. Also remember that if you were to send this patient for a biopsy, the histology on the biopsy will look like inflammatory bowel disease. So on histology, on pathology, it looks like inflammatory bowel disease. So don't make the mistake of calling it inflammatory bowel disease when in fact it's syphilis. So please be careful. The other STD that can look like inflammatory bowel disease is lymphogranuloma venereum caused by chlamydia trachomatis. So keep those things in mind. So these are the clinical diagnoses. And I just want to go very briefly over essentially some important points that I don't want you to forget. The first one is particularly among HIV-infected patients, we can essentially see overlap between the stages of syphilis like with RJ. So RJ had overlap of primary and secondary syphilis, and we've known about this ever since Anne Rampalo and her colleagues described it back in 1994. So keep that in mind. The other thing to keep in mind is that many STDs can give you proctitis, including early syphilis. And remember that it can cause on histology, it can look exactly like Crohn's disease, inflammatory bowel disease. So don't be fooled by that, and don't put your patients on immunosuppressive therapy. It would be disastrous. Also, as I told you before, there's a great paper by Janet Towns, and the paper by Janet Towns essentially says that 30 to 50% of patients with syphilis can present with painful anorectal lesions, and it can also be multiple lesions as well. So keep that in mind. The fact that a lesion is painful doesn't mean that it's not syphilis. So what about syphilitic hepatitis? Syphilitic hepatitis in general is perfectly benign. It is completely treatable, and it usually occurs in secondary syphilis. So by giving the patient a single dose of 2.4 million units of benzathine penicillin, you can completely treat and cure syphilitic hepatitis. Now, why is it important to know about it? Well, it's important because sometimes if you see LFTs that suggest the alkaline phosphatase is very high and the AST and ALT are not that high, on the differential diagnosis is secondary syphilis. We've had several cases that were diagnosed as secondary syphilis based on the LFT results. The provider didn't recognize the rash, but they recognized the LFT abnormalities and said, wait a minute, could this be secondary syphilis? They tested for syphilis, and they found that the patient had secondary syphilis. So it's not of clinical importance, the syphilitic hepatitis, but it can help you think about syphilis if you see these abnormal liver function tests. Now, let's talk about serological tests for syphilis because people get very confused about these serological tests. So remember, there are two different types of serological tests. There are non-treponemal tests and there are treponemal tests. The non-treponemal tests and the treponemal tests are both necessary in order to be able to manage patients with syphilis, all right? So here are a few basic rules to remember, and that will make it very easy for you to be able to interpret syphilis serological tests. The first rule is this: both non-treponemal and treponemal tests will be negative in early primary syphilis. Right? Remember, these are antibodies, and it takes several weeks for antibodies to be produced by the body. And so because these tests are antibody-based tests, they will, in some patients, be negative, particularly in early primary syphilis. So 30% of patients with early primary syphilis, they can come in, have a beautiful ulcer, but their serologies in 30% of the cases will be non-reactive. And so the best test to obtain is either a PCR of the lesion when they have a lesion or a dark field microscopy of the lesion. Now, I know some of you may not have access to dark field or PCR. And so please keep in mind that if you see a patient with a lesion that you suspect the patient might have syphilis, if you can't get PCR and if you can't get dark field, order the serological tests. But remember that in 30% of those patients, they will be negative. So go ahead and treat the patient empirically for early syphilis. Do not let that patient leave the clinic before you treat them for early syphilis. That's really important because the sexual transmission of syphilis tends to occur only in the early stages. But the vertical transmission of syphilis going from mother to unborn child, can occur during any stage of syphilis. That's why it's important for pregnant women to be treated immediately, no matter what stage of syphilis she's in. So now let's go back to these non-treponemal and treponemal tests. Remember, 30% of patients with early primary syphilis will have non-reactive tests. Now, all of the patients in secondary syphilis and early latent syphilis should have reactive serologies. If they don't have reactive serologies, most likely they don't have syphilis. So if you see a patient and you say, oh my gosh, this patient has secondary syphilis, and you order serologies, if the serologies are negative and there's not a prozone phenomenon, and usually what happens is the lab can actually take the sample and dilute it to make sure there isn't a prozone phenomenon. And if there isn't a prozone phenomenon with the non-treponemal tests, and if the non-treponemal and treponemal tests are non-reactive, the patient does not have secondary syphilis. So please keep in mind that these tests are very useful in the secondary, early latent, and later stages. So other things to remember. With the treponemal tests, once positive, always positive. So it doesn't matter if you treat the patient, those treponemal tests, once positive, will always be positive. Excuse me. The non-treponemal tests, they will become positive, remember, and then what will happen is, whether you treat the patient or not, these non-treponemal titers can become non-reactive over time, whether the patient is treated or not. Usually, if the patient is treated, these titers will become non-reactive faster, but in 3 to 5 years after exposure, even if a patient is not treated, these non-treponemal titers may become non-reactive in some patients. So keep that in mind. Non-treponemal titers, they can become non-reactive over time, whether a patient is treated or not. Treponemal titers, once positive, always positive. So those are some very important key points to remember with the treponemal and the non-treponemal tests. Remember also that you can see false positives with both non-treponemal and treponemal tests. With the treponemal tests, a common cause of false positivity is Lyme disease and other non-endemic treponematoses, which are not endemic in the United States but may be endemic in equatorial parts of the world. Some of the causes of false positive non-treponemal tests include collagen vascular diseases like lupus and other rheumatologic conditions. Other infections, certain viral infections, can give you false positives. And old age is a common cause of false positivity of non-treponemal tests. So you can see false positive non-treponemal and false positive treponemal tests. Treponemal tests, once positive, always positive. Non-treponemal tests, when you treat them, the non-treponemal tests can become non-reactive over time, but even if you don't treat the patient, the non-treponemal tests can become non-reactive over time as well. And remember that both non-treponemal and treponemal tests may be negative in 30% of patients who have early primary syphilis. So now, let's go over this algorithm. Now, you can start by screening a patient with a non-treponemal test or a treponemal test. People get very confused about labs that start with a treponemal test. And the reason why labs start with a treponemal test in many places is because of cost-cutting measures. It's cheaper to go and start with a treponemal test. In your case, it shouldn't matter which one is done because now you can interpret all of them. So if the lab starts with a treponemal test, and usually they'll start with either a CIA or an EIA. If the treponemal test is non-reactive, if it's negative, then the possibilities are either early syphilis or no syphilis. Those are the two main possibilities. Either they have early primary syphilis or no syphilis. If the patient is at risk, or if you see some abnormality on the physical exam, you can empirically treat them. And if there's no risk, then you can just tell the patient that they don't have syphilis. If the CIA, the treponemal test, is reactive, automatically the lab will get you an RPR because the RPR titer is what's going to help you manage this patient. So if the RPR is positive, now you have a positive CIA and you have a positive RPR, then you can screen the stage the patient appropriately. You'll go back to the patient and try to figure out if they have early syphilis or late syphilis. Very straightforward. On the other hand, if the RPR is negative, now we have a positive CIA and a negative RPR. We have to make sure that the CIA is not a false positive. And usually the labs will automatically order a different treponemal test. And usually the different treponemal test is the TPPA. And if the TPPA is negative, so now you have a negative TPPA, a negative RPR, and a positive CIA, the most likely reason for the positive CIA is a false positive. The patient has a false positive CIA. On the other hand, if the confirmatory treponemal test, the TPPA, is positive, now you have a positive TPPA, a positive CIA, but a negative RPR, then the patient probably has syphilis, and you have to go back to the patient and get more history. Does the patient have treated syphilis? Does the patient have untreated syphilis? And based on the history, you can decide what to do with the patient. So if you have a positive CIA, a negative RPR, and a positive confirmatory TPPA, you have to go back to the patient and get a good history to find out how to best manage that patient. If they were previously treated for syphilis, there's nothing more to do. If they were never treated for syphilis, you have to treat them for syphilis. So what you will do is you'll do a good neurological exam. You'll examine them very carefully. You'll get a good history. And if everything is normal, they probably have latent syphilis, and you will treat them with 3 doses of benzathine penicillin G. But it's really important to go back and do a good physical exam and get a good history. And that, ladies and gentlemen, is how you interpret these serological tests. So how do we manage patients with syphilis? And the optimal treatment for early syphilis, primary, secondary, and early latent, is 2.4 million units of long-acting benzathine penicillin, 1 dose, given intramuscularly. That's the best regimen that we have. But if the patient is HIV infected with advanced immunosuppression, should we give them more doses of penicillin? And the answer is no. You don't need to give patients more doses of benzathine penicillin G because they're HIV infected. Patients living with HIV are treated exactly the same way as patients who don't have HIV infection when you're managing syphilis. So for early syphilis, the treatment is 2.4 million units times 1 dose, whether you're HIV infected or not. Now, if the patient is not pregnant and has a penicillin, a real penicillin allergy, you can use for early syphilis 2 weeks of doxycycline orally, 100 milligrams twice a day. 2 weeks of doxycycline is just fine in both HIV infected and uninfected patients. We have reasonable data to suggest that it works fairly well. So if they're not pregnant, they have early syphilis, and they are penicillin allergic, you can use 2 weeks of doxycycline. Patients who have latent syphilis are treated with 3 doses of benzathine penicillin G, or 1 month of doxycycline if they're not pregnant and they have latent syphilis. And so early syphilis, 1 dose of benzathine penicillin G. Late syphilis, 3 doses of benzathine penicillin G. Ocular syphilis, otic syphilis, or neurosyphilis, 14 days of IV penicillin. Now, what about pregnant women? The only thing you can use for pregnant women is penicillin. You cannot use anything else, including ceftriaxone. You cannot use anything other than penicillin. So if a pregnant woman is allergic to penicillin, admit the patient, desensitize her, and treat her with penicillin. It is very important that pregnant women be treated only with penicillin. So this is the summary of treatment recommendations, ladies and gentlemen. Early syphilis, primary, secondary, early latent, benzathine penicillin 1 dose, or doxycycline. Latent or unknown duration, 3 doses of benzathine penicillin, or 1 month of doxycycline, 28 days. If I said 3 weeks earlier, correct me, it's 4 weeks of doxycycline, so it's 28 days, I apologize. And then for neurosyphilis, ocular syphilis, or otic syphilis, remember it is essentially 14 days of IV penicillin. The alternate is procaine penicillin IM once daily for 10 to 14 days. Your patients will hate you for it because nobody wants daily IM shots of penicillin. No. RJ has secondary syphilis without any neurological signs or symptoms. Does he need a CSF examination? And that's a question that everybody likes to ask. And the answer is, excuse me, it's a controversial question because he has no neurological signs or symptoms. Right now, the CDC recommends a CSF examination for anybody that has neurological signs or symptoms, patients who don't have neurological signs or symptoms but who have tertiary syphilis because they found in the pre-antibiotic era that those who had tertiary syphilis had a higher rate of having asymptomatic neurosyphilis. The good news is tertiary syphilis is very rare. You'll probably not encounter a lot of those patients. And then the CDC says consider doing a lumbar puncture in patients without neurological signs or symptoms who do not demonstrate a fourfold decline in non-treponemal serological titers following therapy. So if you treat a patient, you wait long enough, and their RPR titers don't come down, the CDC says consider doing a lumbar puncture. We're going to talk a little bit more about that in the next few slides. Hold on. And the following is not a recommendation, but a statement that appears in the guidelines. HIV-positive patients with a CD4 count of less than or equal to 350 or an RPR titer greater than or equal to 132 are more likely to have CSF abnormalities consistent with neurosyphilis. And then the guidelines don't say anything after that. And the reason why is because there are no real data to support doing a lumbar puncture in these patients right now. But we know that HIV-positive persons appear to be more susceptible to neurological complications of syphilis. So everybody's a little bit unsure about what to do with these patients because there are no data, but we worry about neurological complications in these patients. The answer is there is no definitive answer, but I'll just give you a little bit of an anecdote. At the latest CDC treatment guidelines meeting, where all the experts get together to talk about the next guidelines, I asked the question, who amongst you would treat an asymptomatic HIV-infected patient who does not have any neurological signs or symptoms, who comes in with early syphilis? How many of you would actually do a lumbar puncture in those patients? Not a single person raised their hands. So what I'm going to tell you is that while it's still a controversial question, I and many other experts do not do routine lumbar punctures in these patients. So a patient like RJ, whose titer was 1 to 32, and whose CD4 count was less than 350, he is certainly at slightly increased risk of having neurological complications. But even in this patient, I would not do a lumbar puncture. I would just make sure and tell the patient, listen, if you develop headaches, visual changes, hearing changes, call me immediately and we'll bring you back in. So in these patients, I personally and many others would not do a lumbar puncture. So RJ is treated intramuscularly with benzathine penicillin times 1. A CSF exam is not performed. Signs and symptoms resolve within 14 days. He is thankfully cured of his early syphilis. We'll come back to RJ in just a bit. Let's move on to another patient. Patient NN is a 56-year-old transgender woman, HIV infected but well controlled on her antiretrovirals. She presents with, and this is an absolutely true case that we admitted at our hospital a few weeks ago, she comes in with bilateral eye pain, redness, photosensitivity, vision loss, retroorbital headache, and bilateral tinnitus. She first developed a rash over her legs, palms, and soles about a month earlier, and also noticed at the same time some flat, painless lesions on her genitals. These were most likely condyloma lata from syphilis, secondary syphilis. She had gradual development of headaches, followed by right eye pain, redness, photophobia, and blurry vision, with subsequent involvement of the left eye. She was seen in the emergency department initially and was diagnosed with conjunctivitis, and she was sent home. Then she developed tinnitus in both ears, but no hearing loss, and she quickly came back to the emergency room. At that point, somebody said, oh, let's get her to see ophthalmology. Ophthalmology saw the patient and diagnosed her with anterior uveitis. Her laboratory tests again showed an elevated alkaline phosphatase, AST/ALT slightly elevated. Now you know what that is. And then she had an RPR that was 1 to 64 and a reactive treponemal test. So what are the possible diagnoses in this woman? And so these are the diagnoses. She has early syphilis, most likely early latent syphilis, because at the time that she was seen in the emergency room, she didn't have any more lesions of the secondary syphilis that she had earlier. So she clearly has early syphilis. She has neurosyphilis most likely. She has this headache, which is new and different, plus minus photophobia. The photophobia could also be due to her ocular syphilis. She has anterior uveitis. She also presents complaining of tinnitus, and so essentially she has otic syphilis, and she has syphilitic hepatitis. So this is unbelievable because she has essentially all of these clinical manifestations of syphilis, and in this case, the ocular, otic, and neurological manifestations of syphilis are happening during early syphilis when this patient just recently had early secondary syphilis. So pretty amazing story. Now, she has neurological, ocular, and otic signs and symptoms. I'm asking you this question, and please note that it's a very specific question. Will a CSF examination change the treatment recommendations for this patient? So if you were to do a lumbar puncture, would that change the treatment recommendations for this patient? And I'm going to try to answer this question, but I want to go over a few things about neurosyphilis and ocular syphilis first. First, with neurosyphilis, there's no gold standard diagnostic test for neurosyphilis. The CSF VDRL is very specific, so if it's positive, it's very helpful to tell you that this is neurosyphilis, but it's not very sensitive. It's only 50% sensitive. Finding a high number of white cells or pleocytosis in the CSF is very sensitive, but it's not very specific. A lot of things can give you abnormal white cells in the CSF. Also, the protein concentration, a high protein concentration in the CSF is not specific at all. Now, some people have asked, can you use a treponemal test on the CSF to make a diagnosis of neurosyphilis? And the answer is no. Don't use a treponemal test on the CSF to make a diagnosis of neurosyphilis because it is not specific, but you can use a treponemal test on the CSF to rule out a diagnosis of neurosyphilis because it's sensitive. So if the CSF treponemal test, like the FTA, is negative, you can rule out neurosyphilis. If the FTA CSF is positive, you don't make the diagnosis of neurosyphilis. You need other tests to make the diagnosis of neurosyphilis. Now, the good news is with neurosyphilis that with neurosyphilis, you have to have an abnormality on the CSF examination. If your CSF examination is completely normal, if it's completely normal, you can rule out neurosyphilis. And that's why a CSF exam is important when patients come in with neurological signs or symptoms, because if you do a CSF exam and it's normal, you don't have to treat them for 14 days with IV penicillin. So the CSF examination is very important to make the diagnosis of neurosyphilis. But a CSF examination is not that important to make a diagnosis of ocular and otic syphilis. Now, ocular syphilis, remember, can occur during any stage of syphilis and can involve any portion of the eye from anterior to posterior. Ocular syphilis and neurosyphilis are distinct entities with some overlap, but they are distinct entities. The treatment of neurosyphilis, ocular syphilis, and otic syphilis is the same. It's 14 days of IV penicillin. But with ocular syphilis, 30 to 40% of patients will have a normal CSF examination. So please remember that with ocular syphilis, up to 40% of patients will have a normal CSF examination. So the CSF examination will not change management. If you have somebody that you suspect has ocular syphilis and the ophthalmologist tells you, hey, this guy has uveitis, whether the LP is normal or abnormal, you're going to go ahead and treat them with 14 days of IV penicillin. So you don't need a CSF exam to make a diagnosis of ocular syphilis. You need a CSF exam to make a diagnosis of neurosyphilis. You also don't need a CSF exam to make a diagnosis of otosyphilis, because up to 90% of patients with otosyphilis will have a completely normal CSF examination. And the clinical manifestations of otosyphilis are usually hearing loss, ringing in the ears or tinnitus, and vertigo. So if patients come in with tinnitus, ringing in the ears or hearing loss, and you suspect they have otosyphilis, just treat them with 14 days of IV penicillin. You don't need to do a CSF examination because the CSF exam will be normal in the majority of these patients. So CSF exam, necessary for those who have neurological signs and symptoms, not necessary for those who have isolated ocular or otic signs and symptoms. I hope that clarifies this issue. So just to summarize, who should get a CSF examination? Anybody that has neurological signs and symptoms and serological evidence of syphilis, they should get a lumbar puncture, because the lumbar puncture, if it's negative, it will rule out neurosyphilis. Isolated ocular, no. Isolated otic signs, no, they don't need it. Inadequate serological response, the CDC recommends that you consider it in some patients, and we'll talk about that in just a minute. HIV infection with CD4 count less than 350 or RPR, we said it's controversial, but the majority of people would not perform a lumbar puncture in that situation. So here are some questions that you can ask about neurosyphilis when you see a patient. Any patient that you see with serological evidence of syphilis, you should ask them these questions to make sure they don't have neurosyphilis. Ask about headaches, weakness, trouble walking, memory or confusion. And remember, a lot of patients will say, yeah, I have headaches. Then follow it up and say, are these new? Are these different? If they're chronic, they've been around for 20 years, that's probably not neurosyphilis. Same thing with ocular syphilis. These are some questions to ask with ocular syphilis. Change or blurring in vision, flashing lights, floaters in the eyes, pain or redness in the eyes. All of those, again, can suggest ocular syphilis. If you have a patient that has ocular syphilis or neurosyphilis, refer them immediately to an emergency room. They need to be evaluated immediately. Please don't hold off on referring them, because you can have irreversible blindness in these patients. With otic syphilis, ask about hearing loss, ringing in the ears, and dizziness. And so our patient, NN, had ocular otic neurosyphilis. She did undergo a CSF examination mainly because she had neurological signs and symptoms. But remember, even if her CSF exam had come back completely normal, she still had otic and ocular signs. She would have been treated still with 14 days of IV penicillin. So in this case, the CSF exam would not change the treatment course, but in the emergency room, they decided to do the CSF examination, and clearly she had neurosyphilis. So what's the point of performing a CSF examination? The main reason that they have recommended it in the past is because you can follow treatment responses over time. And so they said, do a CSF exam with ocular syphilis because you can follow the treatment response over time, and certainly do a CSF exam in neurosyphilis because you can follow the treatment response over time. It'll be important to repeat the CSF exam at 6 months. But recent data suggests, ladies and gentlemen, that you don't need to repeat a CSF examination at 6 months in patients whose signs and symptoms of neurosyphilis or ocular syphilis respond beautifully to therapy and whose serum RPR titer decline appropriately. So again, just to highlight, if you do a lumbar puncture for somebody who has neurosyphilis, it's important to do it if they have signs and symptoms, neurological signs and symptoms, because it helps you make the diagnosis. But once you treat them, if they do better after treatment and their RPR titers decline and clinically they do better, there are 2 studies that I've summarized here that suggest that in patients who are HIV infected and well controlled on antiretroviral therapy, and those who are not HIV infected, as long as their serum RPR titers come down, you don't need to do any follow-up CSF examinations. And that's good news because physicians hate to do follow-up CSF examinations and patients hate CSF examinations, follow-up CSF examinations. So that's the good news. If you have a patient who's diagnosed with neurosyphilis but who's not on antiretroviral therapy, then you probably need to do follow-up CSF examinations to make sure that their neurosyphilis is being treated effectively. actively. So this does not apply to patients who are not on adequate antiretroviral therapy and who are immunosuppressed. Now, the summary for our patient: she was treated appropriately for 14 days with IV penicillin. The therapy would adequately cover neurosyphilis, ocular syphilis, otic syphilis, and early syphilis. Even if her CSF examination had been normal, she would have required the same course because of the otic and ocular manifestations. And remember, the CSF exam may be normal in a significant subset of patients with otic and ocular symptoms. Now let's go back to our patient RJ very quickly and show you that RJ got treated, remember, and his signs and symptoms resolved. But then at the time of treatment, his titer was 1 to 32. You treat him, you bring him back at 3 months, his titer is still 1 to 32. At 6 months, his titer is still 1 to 32. At 12 months, his titer is still at 1 to 32. He is asymptomatic. He denies any high-risk exposures at the time. He's been monogamous with his boyfriend for the past 9 months. His exam is completely normal, no ocular, no neurological signs. He's doing great. His CD4 count is 448 cells, and his HIV RNA is undetectable. What do you do now? Should you do a lumbar puncture? Should you wait and continue to follow him? Or should you treat him with 3 doses of benzathine penicillin G? This is an example of a patient who has an inadequate serological response. And the answer is essentially, well, let me show you the data. Does the serofast state predict poor clinical outcomes? So do these patients, are they more likely to have underlying asymptomatic neurosyphilis? The data are not great, but this was a recent study that was done that showed that patients who did not have an adequate serological decline were not at greater risk of having underlying asymptomatic neurosyphilis. And so really the data are not very strong to suggest that you're going to find a bunch of people who have asymptomatic neurosyphilis. You decide not to do a repeat CSF examination, great. But does additional antimicrobial therapy make a difference? Should you give him 3 doses of benzathine penicillin because his titers didn't come down? And again, we don't have great data, but the data that we have suggests that it doesn't make a difference. If the patient is asymptomatic and you wait longer and you just follow them, their titers are just as likely to go down as patients who are treated with 3 doses of benzathine penicillin G. And so the answer in most of these patients is probably you don't need to do anything as long as the patient is willing to come back and be followed up. If you're able to follow those patients up every 3 months, you're probably okay. Follow their titers. If they develop any signs or symptoms, you can immediately do a lumbar puncture and treat them appropriately. So don't get frustrated by the patients whose titers don't decline fourfold the way you want it to decline. Now, so what do I do in patients who come in whose titers don't decline fourfold? This is my approach. I hope you find it useful. First, I obtain a really good follow-up history and I do a good physical exam. I don't want to miss reinfection. These patients could have been reinfected, and I want to make sure that I catch those and I treat them appropriately. So if the patient says, oh yeah, I've been having a lot of sex since the last time, I would just retreat them at that point. But if they say, no, I've been monogamous, I've not had any sex, I do an exam, they don't have any lesions on exam, they don't have any signs and symptoms, neurological, ocular, etc., then I ask myself, did I wait for an appropriate time after treatment? Remember to wait a full year after treating early syphilis and a full 2 years after treating late syphilis. If you didn't wait that long, just give the titers time to come down. And with HIV-infected patients, there are data to suggest that their titers come down even more slowly. And so with my HIV-infected patients who have early syphilis, I wait for a full 2 years before I worry about what to do next. And then the next question I ask myself, is this patient reliable? Will they follow up? If they're reliable, if they're going to follow up, then wait. You don't have to do anything immediately as long as you ruled out the possibility of reinfection. So I hope this helps you. This provides a way to manage these patients that don't respond the way that you do. So RJ, unfortunately, his provider decided to do a CSF exam, and it was normal. He's given the first dose of a planned 3 doses of intramuscular bicillin regimen. So let's say today is day day 0. Let's say today's Tuesday, he got the first dose, and you tell him, come back next Tuesday for your second dose. In this case, the physician decided to give 3 doses of benzathine penicillin. I think you could just have waited a little bit longer. But in this case, they decided to treat. That's fine. It's not wrong. And so Tuesday, he gets his first dose, but he doesn't come until Thursday of the following week. Do you start over again, or do you pick up where you left off? And the answer is, well, in non-pregnant patients, up to 10 days between doses is probably okay. So up to 10 days between doses is probably okay. You can just pick up where you left off if it's within 10 days. If it's greater than 10 days, you probably want to start over again. In pregnant women, it has to be exactly 7 days. If they come in on day 8, you have to start over again because the volume of distribution in pregnant women is larger, and you can't guarantee that they have adequate levels on day 8. So if they come in on day 8, in pregnant women, start over again. 6 months after completing the 3-dose regimen of BPG, RJ returns for a follow-up visit. He and his boyfriend broke up, and he reports several new sexual partners with inconsistent condom use. So now his situation has changed. He's had multiple sex partners, and so now that he's no longer monogamous, should we use doxycycline PEP or PrEP to decrease his risk of incident syphilis infection? I know you've all heard about Doxy, and should we use Doxy to to prevent the patient from getting syphilis and other STIs? There is one very small study of PrEP, a randomized trial of 30 patients that showed of using doxycycline every day, once a day, and what they found was that doxycycline decreased a combined outcome of chlamydia, gonorrhea, and syphilis by about 70%. There was a PEP study where 232 MSM were randomized to either 2 tablets of 100 milligrams of doxy to be taken within 72 hours of condomless sex. So they take 2 tablets 24 hours apart within 72 hours of condomless sex. They followed them for about 9 months, and they found essentially a nearly 70% reduction in the hazards for syphilis. And so we have early studies that show that if somebody takes doxycycline either continuously or post-exposure, 2 doses within 72 hours of a high-risk exposure, you can potentially decrease the risk of them getting syphilis. So the pros of PEP and PrEP, it seems to work, it's relatively safe, it's easy to administer, we don't have any other options, and there's greater than 80% interest among MSM. The cons is that it's limited data. We don't have enough data yet. The costs are there. Doxycycline has side effects, esophagitis, sunburn, intracranial hypertension, increased BMI. Also, the impact on antibiotic resistance and on the microbiome are not well established. Ladies and gentlemen, there are 3 ongoing studies to look at doxycycline PEP in patients who are at risk for acquiring STIs, including syphilis. We should probably wait until those results come out before we use this routinely. So should we use doxycycline PEP or PrEP? It's not ready for prime time yet. We need more data before it can be routinely recommended. I know some people are using it. Just be careful. I don't think there are enough data to make a general recommendation for its use. So take-home messages with syphilis. As rates continue to rise, be aware of the less common clinical manifestations. Ask and assess for neurological, ocular, otic signs and symptoms in every patient with syphilis, no matter what the stage of infection. Treatment of syphilis is not impacted by HIV status. Remember that titers in HIV-infected persons can decline in a slower fashion. So give it time. Make sure that they're not getting reinfected, and if you're sure that they're not reinfected, just take a deep breath and give it a little bit more time. Also remember that the use of doxycycline as PrEP or PEP is not yet recommended. I sure hope you found this useful. I want to thank Ethel Weld and Susan Tuddenham from Johns Hopkins for their help with this talk. I also want to make you aware that if you're in the United States and you have questions about any STD, the CDC funds several sites around the country to answer any question you might have, and usually you'll get your answer within minutes to hours after you submit that. Go to the website, stdccn.org, enter your question, and it will be routed to the right person who can answer these questions almost immediately. Please make use of it. It's wonderful. Also to highlight, Seattle group at University of Washington, they have a great STD curriculum with questions, answers, cases. They're wonderful. Also to highlight this monograph by the New York City Department of Health, the Diagnosis, Management, and Prevention of Syphilis. Go to the website, download it for free, and enjoy reading for hours on end about syphilis. And so post-test question now, ladies and gentlemen. Our post-test question, we're going to go back to it and see if you learned anything in this. A 26-year-old man presents with clinical and serological evidence of secondary syphilis and new onset bilateral tinnitus. That's all he has. He has no other neurological or ocular findings. How would you treat him? Perform a lumbar puncture, treat with benzosine penicillin, treat with benzosine penicillin times 3, or treat with intravenous penicillin for 14 days. So remember, this gentleman has otic signs and symptoms, otic signs and symptoms only, no neurological signs and symptoms. Am I pushing you towards the right answer? I think I am. And so make the best decision. And so we're going to close the voting. And as soon as we close the voting, I'm going to tell you that the majority of you are absolutely right. And that in this case, we close the poll, so you can't cheat. In this case, because he only has otic manifestations, the lumbar puncture is likely to be normal. He has no other neurological manifestations, so you can just treat with 14 days of IV penicillin. Well done, 63% of the audience. I'm very proud of you. Next post-test question, ladies and gentlemen. We're going to go to the next one. That's the last one. 62-year-old asymptomatic woman, well-controlled on her HIV, married, monogamous, presents with an initial clinic visit. She has a positive CIA, a positive TPPA, but a negative RPR. Positive TPPA, positive CIA, negative RPR. What should you do? Obtain additional history, treat her with 1 dose, treat her with 3 doses, or perform a lumbar puncture. And so what is the right answer? I think you're going to get it right. I have great faith in all of you. So as soon as we close the poll, I'm going to give you the answer that I think is the right answer. We close the poll, and the right answer is you need more history. Because if the patient says, I was treated before, great, you don't have to do anything. If the patient says, I never was diagnosed or treated for syphilis, then you can examine her, obtain additional history about neurological, ocular, or otic signs and symptoms, and if everything is negative, you can give 3 doses of benzosine penicillin G. Well done, very nicely done. There's one more poll question, and I know you're going to love this one, and everybody's going to get it right. First, type your questions in chat box. I'll try to answer all of them. If I don't get to your question, email me. You have my email address. If you don't Google me, my email address comes out right away. Don't hesitate to email me. I'd be delighted to answer any questions you might have, and I'm going to answer some of those questions now. And remember that the webinar will be available on demand, and evaluations will be available until 5 p.m. Pacific time. Ladies and gentlemen, please fill out your evaluations so that you can get CME credit. When will the evaluation be ready? Ladies and gentlemen, I know everybody's going to get it right. There's always that one person who wants to go with the wrong answer. I think they just do it to make us laugh a little bit. But that's right. It's 5 p.m. Pacific time today. Well done. So now, as you're finishing this up, I'm going to try to answer some questions that you guys have asked. So I'm going to try to answer some questions, ladies and gentlemen. Bear with me if I can't answer all your questions. So here we go. Here we go. Let me just look at presenter notes. Why do MSM get reinfection 3 to 6 months after they get information about prevention? That's a great question. And it's not just MSM. It's actually all patients who are treated for an STD today. We found consistently in almost every STD that you look at that about 30% are going to get reinfected in the next 3 months to 6 months. That's why it's so important to bring them back in 3 months and rescreen them to make sure that they didn't get reinfected. Because often what they'll do is they'll go back, have sex with their partners, the partner wasn't treated, they get reinfected, and so that's a problem. So it's not just MSM, it's in fact everybody that gets diagnosed with an STD. How does meth use increase the risk of syphilis infection? It has to do with risk behavior, and it has to do with networks mainly. It's less likely necessarily biological, and it's more likely network related. Higher risk networks associated with meth use, decreased behavioral inhibition, so there's disinhibition and increased likelihood of certain STDs like syphilis. These are reasons why we are failing at handling the epidemic. Any data or info on how we are failing at prevention? Absolutely. I mean, we're failing at prevention, and that's one of the main reasons why we're failing at the epidemic. I mean, remember, prevention is screening, and we're not doing a great job with screening. Prevention is also treating the partners that are infected, and we're having a harder time finding those partners. So a failure of prevention is also a failure of management and leads to increasing rates. Thank you for that question. Will you address Doxy for syphilis prevention? I did. It's not ready for prime time. Now, I'll just tell you, there are certain patients where, you have to have a discussion with the patient, and you could potentially consider doxycycline. It's not ready for prime time on a population level, but I have to tell you, on 2 of my patients, I have used doxycycline because their risk is so very high. We've talked about the pros and cons, and we decided to use it. Having said that, I just don't think it's ready for prime time just yet. But you have to use your best judgment when you're dealing with these patients. So, is it possible to have neurosyphilis in the early primary stage before the organism has become systemic? Absolutely. Neurosyphilis can occur even before primary syphilis. Otic syphilis can occur even before primary syphilis. So when I say ocular, otic, and neurosyphilis can occur during any stage of the infection, I'm telling you the truth. It can occur at any time. That's why you have to ask the right questions every time you see a patient. And let me tell you something. It takes only a few minutes to ask those questions. Less than 2 minutes, you can ask about neurological signs and symptoms, ocular signs and symptoms, or otic signs and symptoms. So please ask those questions. If you're unsure of whether it is early latent or late latent syphilis, do you just treat as late latent? Yes. If you're unsure if the patient has early latent or late latent, you can treat them as unknown duration, and the unknown duration treatment recommendation is 3 doses of benzathine penicillin G. That is the treatment of late latent. So you treat them as if they had late latent disease. Excellent question. Thank you. Can the speaker comment on commercially available FDA-approved PCR for T. pallidum? Yes. There are PCRs that are commercially available for T. pallidum. Most of them are not FDA cleared, but the big commercial labs have done in-house validation for them for patients that have lesions, usually primary lesions. So if you have a patient with a primary lesion and your laboratory offers a PCR, in general, these tests, although most are not FDA cleared, in general, these tests are actually pretty good, and you can certainly use them. However, a lot of people don't have access to these tests and don't have access to dark field microscopy. And so in the patients where you see a lesion, but you don't have access to these tests, send serologies, but even before those serologies come back, treat them with a dose of benzathine penicillin G. Another question that comes up is why are VDRL and RPR not interchangeable? And that's a great question. And the reason is because they will give you different titers when you do them. Remember, the VDRL is not a visual test. You have to look under the microscope to look at flocculation. On the other hand, the RPR, it is a visual test. You can see flocculation with a naked eye. Because of that, the sensitivity is different between RPR and VDRL. So while you can use either the RPR or the VDRL on serum to follow patients, don't use them interchangeably. If you start using the RPR on a patient, follow up with the RPR on that patient. If you start using the VDRL, follow up with the VDRL on their patient. They're not interchangeable because the titers are different if you get an RPR and VDRL. Usually the titer difference is 1 dilution, but it's not always the case. So the recommendation is not to use them interchangeably. Isabel asks, do you also follow up with big ×3 after neurological treatment of syphilis? So that's a question that we always get. After I finish 14 days of IV penicillin, should I give 3 more doses of benzathine penicillin G? And the answer is we don't know, right? We don't know if the additional doses offer any additional protection. And so the CDC has not made a recommendation to do that. I have given 1 additional dose of benzathine penicillin in patients who are treated for late neurosyphilis, late ocular syphilis, and late otic syphilis if I was able to give that dose. I usually give it on the last day that they get their IV penicillin. The reason why I give it, it's purely theoretical. It's a theoretical reason. The reason why I give it is because it often takes 21 to 28 days to treat latent syphilis, latent syphilis in the late stages. And so because 14 days of IV penicillin is not quite enough, the theoretical benefit of adding 1 more dose of benzathine penicillin may exist. However, we don't have any clinical data, and so I wouldn't lose sleep over it if you can't give your patients with late ocular or neurosyphilis an additional dose of benzathine penicillin. Don't lose sleep over it. Can you repeat what he said about inflammatory bowel disease? Yes. Both lymphogranuloma venereum, LGV, that's caused by Chlamydia trachomatis, and early syphilis, proctitis, looks exactly like inflammatory bowel disease, Crohn's disease, if you do a biopsy and you actually look under the microscope. That's why it's important in your sexually active patients who come in with proctitis symptoms, diarrhea, pain on defecation, bloody defecation, mucus, etc. Make sure you ask them about exposures. That way you can test them for chlamydia and syphilis and not make the mistaken diagnosis of Crohn's disease in these patients. So now, I'm going to keep trying to answer these questions. If the CD4 count is too low and FTA-ABS is not detected and RPR or VDRL is positive for more than a year, isn't LP indicated? So remember, the LP is absolute indication is for neurological signs and symptoms. The CDC says consider an LP if the titers don't come down after treatment and if you've waited an appropriate amount of time and if you've ruled out reinfection. But remember, the CDC says consider an LP in this situation. They're not saying you must do an LP. Consider an LP. Who do I consider an LP? If the patient is not reliable, if the patient does not follow up, and they come in and their titers have not come down, and I don't know when they're going to come back again, in those patients, I would consider an LP. But if my patient comes in and they're asymptomatic and they're doing well and they're well controlled on their antiretrovirals and they were not reinfected and everything looks hunky-dory, I would just wait and not do an LP. Even if their titers don't come down, I would just follow their titers over time. I know this is confusing, but again, if you do a good physical exam, if you ask the right questions, you don't necessarily need to do an LP in these patients whose titers don't come down. Here's another question. Does pretreatment with IM bicillin change the CSF enough to make the parameters negative? That's a great question. So let's say you see a patient and they have some neurological signs or symptoms, and you say, I'm going to send them to the emergency room. But you decide to give them a shot of benzethine penicillin. It's going to take days before that shot of benzethine penicillin has any effect on their CSF, if any. So please keep in mind that I've had a lot of people tell me, listen, Dr. Ghanem, I want to send the patient to the emergency room. I'm not sure if they're going to go to the emergency room, so I give them this dose of benzethine penicillin. Is it going to affect their CSF results? And the answer is, in the relative short term, in the next 3 to 7 days, it's probably not going to affect that much the CSF findings. So I don't think that it would make a CSF negative in somebody who truly has neurosyphilis if the CSF is done within the next day or 2, 3. So that's my best answer, but I'm not aware of any data that have looked at that. So just FYI, this is my best answer. So if you diagnose someone with syphilis and the only symptom sign they have is conjunctivitis, would you treat them for ocular syphilis? So the answer is, if you have no other reason for them to have conjunctivitis, then yes, you treat them for ocular syphilis. That's my best answer. But if they come back and they tell you, oh yeah, I have conjunctivitis, 3 months out of every year, then no, I wouldn't treat them. So if it's a new onset conjunctivitis and I don't have an alternate explanation for that conjunctivitis, then I would treat them for ocular syphilis. Would you treat a clinical case of early syphilis before lab results? And that's from Arlene. And absolutely, Arlene, I would treat them empirically because the lab results for early syphilis, remember, if it's primary syphilis, if you're only getting a serology, it may be negative, even if the patient has syphilis. Also, I never let a patient leave my site if I suspect they have early syphilis. Because remember, particularly primary and secondary syphilis, they are the sexually transmissible stages. If you let that patient go and tell them to come back in 3 days, they could transmit it to 10 different partners in those 3 days. You don't want that to happen. So with primary and secondary stages that are the sexually transmissible stages, I usually, it's going to be a day or 2 or 3 before I get the results, I will usually treat them empirically. There's no downside really to doing that. Anthony asks, would it be reasonable to give BIC ×1 before sending for LP in a patient with otic syphilis? Yes, absolutely, Anthony. It's not unreasonable, but just make sure you send the patient with otic syphilis to the emergency room so they can get a PICC line in place and they can get 14 days of IV penicillin. Ladies and gentlemen, please call the emergency room when you're sending somebody over and say, listen, my friend, I'm sending somebody that I suspect has otic syphilis. They need to be admitted to get a PICC line and get IV penicillin. The LP is not necessary because they only have otic signs and symptoms, and the LP will be negative in up to 90% of these patients. We had several patients who were referred to the emergency room with otic signs and symptoms, and the LP was done in the emergency room. It was negative, and the emergency room doctor told the patient, guess what? You don't have otic syphilis. Take care. And we had to bring the patients back and essentially admit them, put a PICC line in them, and treat them with 14 days of IV penicillin. And so the next question, okay, so would your decision to LP or retreat RJ be different if he returned with no RPR decline at 1 year, if he was on no ART and CD4 was very low? The answer is, I think it depends. If RJ was consistently following up with me and if he was asymptomatic, then I probably would still follow him. On the other hand, If RJ was being inconsistent in his follow-ups and I wasn't seeing him frequently and I was worried, then I would send him for a CSF examination just to make sure he doesn't have underlying asymptomatic neurosyphilis. So, ladies and gentlemen, a lot of you have asked the same question, and I know you're frustrated by the fact that there is no clear, definitive answer. But I think because we don't have data, it's hard to say definitively yes or no. In this case, what I would recommend is that you use your best judgment. Do you think, if something bad happened, do you think this patient would come back to see you? If this patient is not very reliable, do a lumbar puncture. If the patient is reliable, you think that they would be able to access health care in a timely manner, you probably could defer the lumbar puncture when they are completely asymptomatic. I hope that answers the question. Is the vaccine ready yet? Great question. Unfortunately not. And the vaccine is probably at least a decade away, I'm sorry to say. Does the prozone effect only impact the RPR-VDRL or also the CIA and the CIA-TPPA? The prozone effect only impacts the RPR. It does not impact the treponemal tests. So the prozone effect is mainly seen in secondary syphilis, and what you do is if you suspect somebody has secondary syphilis and the RPR is negative, you can call the lab and say, my patient I think has secondary syphilis, can you dilute the RPR and check it again? And when they dilute it, they will find a positive RPR, and that's usually called the prozone effect. And it has to do with the very high antigen load that is found in secondary syphilis. So another question is, retreat patients if exposed again after treatment within 2 weeks, or retest the RPR? My advice to you is, if they've been exposed very recently, go ahead and retreat them. Don't wait for the RPR. Go ahead and retreat them. So if there's a high-risk exposure, certainly you can send the RPR, but don't wait for the results. Go ahead and retreat them. So another great question. If the RPR is 1 to 16 today, but the patient is not treated until a week later, do you get another RPR? And the answer is yes. Get another RPR. Try to get the RPR on the same day as treatment, because it's useful when you want to follow these RPRs over time. You can have a patient who's 1 to 16 today, and then let's say they don't get treated, and then you bring them back a week later, their RPR could be at 1 to 256 a week later. It depends on when you catch them in the course of the infection. And it's important to know what it is on the day of treatment, because that way you can follow them over time and make sure that their titers are declining appropriately. And please remember, with RPR titers, a fourfold decline is a cure. A fourfold increase is either reinfection or treatment failure. Fourfold decline is cure. Fourfold increase is treatment failure or reinfection. Thank you for that question. With IV penicillin, can you do a continuous infusion? So if you're treating neurosyphilis, ocular syphilis, or otic syphilis, and you're using IV penicillin, you absolutely can do a continuous infusion. You don't have to do a continuous infusion, but it's perfectly fine if the patient prefers it or if the insurance company mandates it. You absolutely can do a continuous infusion. In what situation would you work up a patient with advanced dementia for late neurosyphilis? That's another great question. And so the answer is this. Technically, somebody who has serological evidence of syphilis and they present with dementia, right? They have neurological signs and symptoms. And the recommendation from the CDC is to go ahead and do a lumbar puncture. In this case, the lumbar puncture is important because if you do the lumbar puncture and it's negative, you rule out neurosyphilis. You don't have to treat the patient. You rule out neurosyphilis. And it's really hard because what happens invariably is you'll get called to see a patient and their titer, the RPR titer is non-reactive, and their treponemal tests the CIA and the TPPA are positive, and the patient is a 90-year-old man who has dementia. And so you go back to the patient. You can't ask them any questions about their past history. You go back to the family and you say, did your father ever have syphilis? And the family goes crazy. They start being anxious, etc. So you can't really go back to the family. The first thing I do is I go back and I call the health department and say, do you have any data on this patient? Were they treated before? If they were treated before and everything was fine, I usually don't retreat and don't look for neurosyphilis. On the other hand, if the patient was never treated or they have no data, then you're stuck because it could be neurosyphilis, but most likely it's not neurosyphilis. And so you have two options. You can follow the CDC treatment guidelines that says do an LP. If it's positive, treat them for neurosyphilis. If it's negative, don't treat them. The other option, when the pretest probability is low for neurosyphilis, a 90-year-old patient who has many reasons to have dementia. What I usually do is I give them 3 doses of benzathine penicillin G 1 week apart. Let me tell you why. In the late 70s, early 80s, all the way from the 60s to the early 80s, 3 doses of benzathine penicillin was an alternate approved regimen to treat neurosyphilis. Then in the early 80s, they found that it didn't achieve high concentrations in the CSF. And so the CDC said, please don't use it anymore to treat neurosyphilis. But we have data on 15 years worth of its use, 15 to 20 years, and it wasn't too bad. It wasn't great, but it wasn't too bad. And so in cases where I think the likelihood of neurosyphilis is very low, particularly in non-HIV infected elderly patients who have many reasons to have dementia, I will sometimes say forget it, don't do the LP, just treat them with 3 doses of benzathine penicillin G. Will the CDC be upset at me? Perhaps, but that's just what I do when I think that the pretest probability is low. I would never do that in somebody that I know has neurosyphilis or in somebody that I think has a moderate to high probability of neurosyphilis. I only do that when the pretest probability is low and I think that an LP is going to be more harmful for the patient than it's going to be useful. So I hope that answers your question. I'm going to finish up. So Anthony asked, what if the second case study has had ongoing risk for syphilis after prior treatment for syphilis? Could the EIA and TPPA with a non-reactive RPR be indicative of a new latent infection? Anthony, yes, it could be an indication. But remember, it usually takes the RPR a few years to become non-reactive after an exposure that's untreated. So while it is possible, the likelihood is fairly low, particularly if the exposure occurred in the last few years. So, but honestly, if you get a history, a high-risk history of re-exposure, go ahead and think about retreatment, irrespective of what the RPR shows. I just got one more. Is 10 days okay for neurosyphilis? CDC says 10 to 14 days. Yes. 10 days is fine. 14 days is fine. 10 to 14 days, perfectly fine. Can you get infected again if you have early latent already that isn't treated? And the answer is, if you have an infection and you get treated, you automatically become susceptible to getting reinfected immediately after treatment, and you can get an ulcer again. If you have an infection that is untreated, you are unlikely to get super infected with an ulcer. We know this from some of the studies that were done, the highly unethical studies that were done in Sing Sing prison, where they tried to infect prisoners with syphilis while they were still infected with syphilis. And you don't really find ulcers. Now, I just want to highlight one thing. So you're not going to get super infected if you're not treated and you're already infected with syphilis. Now, I want to highlight one thing. There are data to suggest that patients who have syphilis, who are treated, when they get reinfected, those patients may be more likely to be asymptomatic when they get reinfected. so they're less likely to have a chancre or present with florid secondary syphilis. There are some data to suggest that, and so keep in mind that sometimes reinfection after treatment may be asymptomatic. So if you're looking for symptoms, you may miss these patients, so make sure you ask about exposure and you make sure you screen those patients. If RPR goes from non-reactive to 1-to-1, is it a new infection? Well, those RPR questions, right? They're really tough. So the answer is it depends on the exposure. If somebody comes in and says, I've been monogamous, and their RPR went from non-reactive to 1-to-1, no, it doesn't mean anything at all. If somebody says, yeah, I've had 5 sex partners in the last month, in that case, perhaps the RPR means something. So the answer is these titers have to be interpreted in the context of what is going on with the patient. And that's why it's so important to develop a mutually trusting relationship with the patient so they tell you what's going on in their lives, and that way you can assess appropriately what to do in these situations. Is there an upper limit of sustained RPR at which you would not consider a patient to be serofast? So that question is a great question, and it was asked by Janice. So it's a tough question to answer, mainly because people get anxious when the RPR, so let's say you have a patient who's 1 to 2,048. Their initial RPR is 1 to 2,048, and they have early syphilis. And you give them a dose of benzathine penicillin G to treat their syphilis. And you wait for a year, and the RPR, and they come back, and their RPR is down 4-fold, but it's still at 1 to 256. So they're at 1 to 256. They went down 4-fold. That's a cure. But should you be worried that it's hanging out at 1 to 256? And the answer is, and Janice, I don't know if you're going to be satisfied by that answer. The answer is probably not. It's probably not something you should be concerned about. As long as the titers go down 4-fold, you're going to be okay. Now, having said that, there are, in the pre-antibiotic era, some data to suggest that these high titers, those patients are more likely to relapse if you follow them for many, many years. But in the antibiotic era, we don't have such data. And so, in general, I don't worry what the RPR titer is. As long as it's gone down 4-fold, I'm happy. I don't worry about the titer once it goes down 4-fold. So I tried, ladies and gentlemen, to answer all the questions that I have been given. I hope I may... here's another question. Any tips on how to secure prescriptions for benzathine penicillin? It seems that health insurance require a prior authorization and fight it. That's horrifying to hear. I've never heard that before. It is absolutely necessary to have unfettered access to benzathine penicillin G long-acting when you're treating patients for syphilis. So I'll be honest with you, I've never had this come up. I would call the insurance company and yell at them. Yes, I give you permission to scream at them because it's such a critical drug. If you ever have problems, I don't know where you're from, but I would call your local health department and try to come up with possible solutions there. The local health department can be a great resource if you are having problems getting your hands on benzathine penicillin. Right now, there are no shortages of benzathine penicillin G in the United States that I'm aware of. Lisa is asking, if it takes 21 to 28 days to treat late neurosyphilis, why don't we treat these patients with 21 to 28 days of IV penicillin? Lisa, that's a great point. The answer is it doesn't take 28 days to treat neurosyphilis. Neurosyphilis can be well treated with 10 to 14 days. But what you're trying to treat is the underlying syphilitic infection that exists outside the central nervous system, assuming that there are pockets of